Yeah, thank you very much, sir. At the outset, I would like to thank the Diabetes Association of India, West Bengal, for this opportunity, and especially Sujay Ghosh, sir, for this opportunity. It's always a pleasure to debate. And today's topic, I'll be talking that insulin is relevant today, and it will always be. So we are concerned about the future here and about relevance, and what is relevant and what is future is sort of subjective, and I'll leave that to your own imagination. From my perspective, relevance is something that is always going to be useful to patients, and future is something that we can see, maybe 10 years or maybe 15 years at the maximum. So that's what I think. And before we go into the presentation per se, we are not going to talk about situations where insulin is the only viable choice, such as type 1 diabetes, pregnancy, or emergencies. Why in type 2 diabetes would insulin be relevant in the future is the motion. And for that, I give you four important reasons. Number one is the numerical reason, number two, biological, number three, and least talked about, the economic reason, and number four, the evolutionary reason. Let's start with the numbers. Numbers count in any situation, and this time it's no different. A beautiful map of our country from 1990 to 2016, just under one generation. The prevalence of diabetes has gone up significantly. So we have a huge number of people with diabetes. Not only that, we also have increasing life expectancy, not just in the richer southern states, but all over the country. So what we have is a huge pool of diabetes patients who are getting older, who are having complications of diabetes. And what do they find out? They find out that biology is the boss, the number two reason. And what do I mean by biology is the boss? This is how a diabetes story goes by and large. First, we start with metformin, then certain other stuff is added. It could be tablets, it could be injections, and so on. And finally, the patient agrees to insulin therapy. So this is how it goes on. Sometimes upfront combination therapy can be used. It's an upcoming modality. But however, this is how diabetes story usually unfolds in most of our patients. Now, as you can see from the story itself, all roads lead to Rome, and all diabetes ultimately leads to insulin. Insulin is irreplaceable. It can be given to any patient in any condition, in any comorbid situation, and so on. So ultimately, the biological reality is that all patients would require insulin, and it is the end game of therapy. You could give some secretagogue to stimulate insulin, just like just nudging the ball with the stick here, or you could directly put the ball into the hole like SGLT2 inhibitor. One way or the other, the only reason how all other therapies will work is if you have a pancreas, and if you need pancreas, you need insulin. That's it. So that's the biological reality. Even if we discount the biological reality, we have to face this third reality called money. It's not often talked about because it's not considered polite, but that's just the way things move. So the average budget for a patient in India is widely varying because this country is large and diverse, and what is applicable in Kerala is probably not applicable in Assam and so on. But this is an approximate number of 3,000, say, found in many articles. So this is how much a patient spends per month on diabetes. This includes consultations, labs, tests, injections, and so on and so forth. So you can see that money is a very important part of treatment in India. And one of the common refrains against insulin is that, does it really protect the heart? Now, before answering this question, we all know that hyperglycemia itself can harm the heart, and of course, insulin relieves the hyperglycemia. But before that, we need to understand that there's something in front of the heart, and that something is your pocket. So the road to the heart basically goes through the pocket. It's all nice and dandy to say that some drug protects your heart, but if I'm not able to afford the drug today here, then obviously that drug is not going to be of any use to me. So this is demonstrated very convincingly in n number of guidelines that we have seen. This is just a ADA guideline. We have all seen this thing ad nauseum. what is important is that there is a vast difference between what the experts say you should do and what actually happens in reality. This is from a rich Western country, the UK. The compliance with the guideline, and you can see that GLP-1 receptor agonists are no longer, they don't even figure in the whole scheme of things. The usage is so less that they don't even figure in the scheme of things. The only injectable that even shows up is insulin. No other thing just shows up. That is because the guidelines and reality are conflicting on the use of drugs, and it has something to do with money. And while we may want to do what is on the left, the rod of Asclepius, to be good and do good to the patient, you also have to look at what is on the right. And if you look at these two images, you will find that they look very similar, but they're not really the same. So money cannot be just wished away. And insulin fits all pockets, the fancy pocket, the not so fancy pocket, and so on. So if these three reasons are not enough, we can see that change is the only concept, the evolutionary reason. While other drugs evolve, as others have pointed out, other drugs evolve over a period of time, newer drugs keep getting added. Insulins don't remain static. It is not just a molecule of life, but a living molecule. And a living molecule changes, becomes better over a period of time. So what kinds of evolution happens? Insulins go from a clock time molecule to a calendar time molecule. In previous days, you might say that insulin, oh, it's 9 o'clock, it's time for my insulin. Perhaps in the future with iCodec, people may say, hey, it's Sunday, it's my time for insulin. It can be given through the nose, on a pump, and so on. Insulin basically evolves just like any other medicine. And all of these evolutions give convenience. At the same time, they do not compromise on control. So the holy grail of convenience and control is being achieved by the evolution of insulins. Not only that, several insulin avatars are up in the horizon. Some of them are liver selective insulin, some of them are oral insulins, the so-called peptide in a pill, and there are even smart insulins or glucose responsive insulins. Of course, none of them are in day-to-day use as of now, but we must remember that we are talking about the future, and the future can hold anything. And what is now and here is that we have seen that the flatter insulin gets flatter and flatter, the faster insulins get faster and faster, ironing out some of the kinks that were originally present in the insulins. So to summarize, there are numerical reasons, biological, economic, and evolutionary reasons why insulin will continue to remain relevant in patients with type 2 diabetes. And if insulin were Mark Twain, it would say that reports of my death have been greatly exaggerated. So insulins will always continue to be, but in only one circumstance I can think of insulin losing its relevance, and that is when the hell freezes over, the seas dry up, or the stars drop from the sky. Thank you so much for listening, and over to the organizers.